Hello, everyone, and welcome to the sixth lecture in the course and our final lecture on drugs and the brain. Okay, so last week's discussion questions. First, good participation rates. We got some good comments. I'm going to start with our question about chemical synaptic transmission. So the question was why most neurons, almost all your neurons, use chemical synaptic transmission. They release neurotransmitters that then diffuse across to the postsynaptic neuron, which then initiates a signal. Why not just have electricity all the way through? Why not have neurons connect to each other using electrical synapses, where the action potential in one turns into the action potential in the next one? So that was the question. And one idea that came up was efficiency. And in this case, that's sort of a mixed bag in terms of how efficient this process is. Uh, it's efficient in one sense, which is in electrical synapses, where an action potential in one cell is just transferred to the next. There's a loss of signal. So passing from one neuron to the next attenuates, diminishes the strength of that action potential. So in a chemical synapse, it's initiated anew. So you generate a whole new action potential. So it's efficient in that sense. Um, it's also efficient in the sense of having different chemicals as opposed to just one kind of signal. If you just have one kind of signal, then what you might need is different kinds of neurons, different kinds of structures that mean different things. We'll get to that here in a minute. Uh, but in terms of energy, chemical transmission is actually not very efficient. Uh, releasing neurotransmitters, taking them back up. Sure, you're recycling the material, but actually it takes a lot of energy to create neurotransmitters, to send them down to the axon terminal, to release them, and then to pull them back in. All that is very costly. It's one of the reasons why your brain consumes 20% of your energy budget, despite being only 3 pounds of your body weight. So it's not efficient in that sense. One other idea that came up was that you have a variety of signals with chemical transmission. You have different neurotransmitters, and these neurotransmitters can cause different effects. You can have different neurons that are structurally similar, so you don't have to reinvent the wheel, so to speak, but they can release a different chemical from one neuron to the next. And releasing those different chemicals gives you some variability, gives you some variety. You can also sort of modify the signal in terms of how much neurotransmitter is produced, how much is released, what are its effects on that postsynaptic cell, because you can modify how many receptors are out there. So you have some more customizability, more variability. And that means you can be more nuanced with what an action potential means coming from a particular neuron. Uh, so those are the main points, I think. It's not as efficient in terms of energy usage, but it does give you a lot more variability, a lot more power in terms of what you can say with an action potential, with variable neurotransmitters, amounts of neurotransmitters, amounts of receptors. These things all give you extra communication ability. The other topic was I entitled "My Brain Made Me Do It." And here the idea is if it turns out that drug use has genetic components, and it turns out that it does, uh, what does that say about uh, our responsibility for actions when we're under the influence, or our responsibility to use illegal drugs in the first place? And of course, one of the centerpieces of this debate is the idea of free will. And this comes up over and over again. People say, well, you know, maybe you don't have as much choice when you're under the influence of drugs, but you chose to take drugs in the first place. And of course, there's a question as to how responsible you are for your choices under the influence. Uh, but of course, all of this presupposes the existence of free will, our ability to choose, to control our own behavior. And this is actually sort of an open question. You know, this has been a subject of philosophy for centuries. whether we choose our own behavior, or whether we have things like destiny or fate. Uh, and there's some evidence that's fairly recent, um, that maybe we don't have free will. It depends on your definition. So, for example, some definitions of free will have the concept of unpredictability. So, if I'm really choosing my own actions, uh, it means you can't predict them. So, if you can predict me, predict my behavior, then I'm essentially a machine that can be predicted, its future can be written down. And so, under some definitions, that means the individual does not have free will if you can predict everything they're going to do. What's interesting is that there's somewhat recent neuroscientific evidence that we can measure what someone's going to decide one way or the other before they're even aware of making a decision. So certainly before they make the decision, before they register it or select it or whatever it is they do, but even before they're aware of having made up their mind, there are measurements one can make that indicate which choice a person is going to make, and so that's that calls into question uh, to what degree we have free will and how do we define free will. And another big distinction in this discussion was uh, the difference between when you're already dependent on drugs, in which case people largely acknowledged you don't have as much control over your behavior, versus when you initiate drug use. And this is a fair point. Again, it gets back to what degree we have autonomy over all of our choices. Uh, we could be predisposed to initiate drug use by genetics, by our environment. If you were raised in an environment that encouraged or um, otherwise condoned drug use, are you more likely? And of course, we don't really have that much control over the environments in which we're raised. So this is something out of our control. We're going to have a big influence on our behavior. What does that say about our responsibility for initiating drug use? And as always, my point here is not to come down on one side or the other of the debate. It's just to further the conversation, to bring up things that maybe we hadn't thought of before. And so when you're saying, well, once you're dependent, you're not as responsible, but you're responsible for initiating, well, there may be factors that influence you to initiate drug use already, and so that also sort of mitigates uh, how much control we have over that choice. There are also personality traits, things like novelty seeking, which is the propensity to look for new stimuli, to seek out new experiences. That's a personality trait. It seems to have a genetic component. So there's that as well. To what degree do we inherit our personality traits? And then those, in some degree, determine our behavior. And of course, this is a big issue for our legal system. Um, our legal system often makes a binary distinction. This person is responsible for their actions. This person is not. This person is legally insane, therefore not not to be punished for their behavior. This person is sane and therefore bears the full weight of punishment. And that's convenient for our legal system because if you're responsible, the legal system takes one course of action. If you're not, it takes another. But that binary distinction may be artificial. That may not be the most accurate depiction of reality, depending on the environment that you're in, or the way you were raised, or your genetics. All these things can come into play, and maybe you're 100% responsible, maybe you're 50% responsible, 80%. Um, all these influences don't act in a simple black or white manner. Uh, there may be shades of gray. It may be that somewhere between no responsibility and total responsibility is the right way to cast this problem. Um, Now, that may be very inconvenient for the legal system, so that, even if true, may never be implemented. Uh, but again, we would just think about this problem a bit. Maybe responsibility doesn't come in two flavors. Maybe there are intermediates. Okay, so that's it for last week's discussion. Good participation, good insight. Again, keep on participating, and those questions are already posted for this coming week. So I'll look for your responses there. Okay, so by way of overview, uh, as before, we're looking at drugs and what they do to the brain. We've already looked at neurons and even multiple neurons put together in synapses. And last time we started talking about the brain as a whole. And we'll start talking about the brain again in this session. Um, but again, we've already sort of covered the parts of the brain. Now we'll talk about the brain in the context really of the entire body. So in this session in particular, what we're going to do is start talking about categories of drugs. This is going to frame sort of the rest of the course. The next couple of weeks, we'll talk about things like drug regulation, drug policy, and after that, we'll start talking about individual drugs. So this is sort of framing that setup. We'll learn about the various methods of administration, routes of administration. That is, how do we get drugs into the body? And then we'll talk about some of the long-term effects of drug use, things like tolerance. How does tolerance develop? Why does tolerance develop? Uh, and so that's going to be this lecture. Uh, Next week, we'll start talking about drug use and its social implications, in addition to its biological ones. Okay, so there are lots of drugs. There are lots of substances that affect behavior. And there are so many, it's hard to keep them all in mind. So one convenient thing to do is categorize them. So how do we categorize that? What system do we use? On what basis do we classify a drug? Do we look at its chemical structure? That is, its molecular configuration. There are a lot of drugs that are very similar to one another chemically. And oftentimes they have similar effects. But is it the chemistry that we should focus on? Or is it the behavioral effects? Is it what the person's behavior, what their perception becomes as a result of using the drug? Its purpose. So some drugs may have a variety of effects, and another drug may have very limited effects, but they're intended for the same thing. They could both be pain relievers. Some pain relievers have more effects than others. So do we categorize them by what they're intended for? What about their legality? So that's sort of a social perspective. Do we talk about drugs and categorize them based on whether they're legal or not? So for our purposes in this course, we will talk about the legality of drugs, but just as a framework for describing different drugs, that's not as useful, primarily because laws change over time and they change from place to place. So categorize them by legal or illegal, by that distinction, isn't a very rich explanation. Again, it's sort of a binary explanation. And there are lots of different drugs and lots of different things that drugs do. And here we're interested really in behavior. This is a drugs and behavior course. So what we're going to do is categorize drugs for our purposes by effect. What the drug does to the body, to the brain, to behavior. And if we do that, we come up with a variety of categories. So your book here has 7, and these are 7 pretty common categories. There are the stimulants that increase excitability, increase wakefulness, alertness. These are things like cocaine, which is not legal, and caffeine, which is. There are depressants, and these really have a wide variety of forms, chemically speaking. There's something as simple as alcohol, ethanol, very simple molecule, wide variety of effects. Other things like Valium, which is a benzodiazepine. Chemically very different from alcohol, but has these depressant effects. It increases restfulness, relaxation, sleepiness, to varying degrees, but this is something that's common to depressants. There are opioids, and opioids are called opioids because they're chemical derivatives of opium and the chemicals contained in opium. And we'll talk about that. We have a whole unit on opioids. But these are pain relieving agents. There are hallucinogens. So these, as the name suggests, produce things that are technically not hallucinations. They're more sensory modifications, but they're called hallucinogens, so we'll go with it. And these are things like LSD, psilocybin, things that perturb usually our visual perception. There are psychotherapeutics. that are used to alleviate mental disorders and mood disorders especially. There are a lot of things like antidepressants, but also things like antipsychotics, things that relieve symptoms of disorders like schizophrenia. Nicotine is sort of a category unto itself. In many ways, it is a stimulant, but in some important ways, it also has effects with depressants. People take cigarettes, use cigarettes, both um, to have those excitatory effects, but also to relax. So this combination, this unusual combination of effects in the case of nicotine and smoking. There's also marijuana. Marijuana has sort of a combination of effects. It is historically sometimes classified as a depressant, but in sufficient quantities, it can act as a hallucinogen. So again, it has this combination of effects, so we kind of put it in its own category. And of course, there's not just the category that a drug belongs to, there's also what we call it. So there are naming conventions, and fortunately for biochemists and pharmaceutical companies, there are a variety of names that are convenient for them. Unfortunately for us, it means the same substance has a variety of names that we sometimes have to be aware of. So there are different names for a drug. There is chemical name. So this is a description of the chemical substance. So diacetylmorphine, for example. So that indicates that it's a morphine molecule that has two acetyl groups attached to it. But unless you're a chemist, that's not very accessible. So the company that develops the drug will often have a generic name that's a little bit simpler. And so if you see commercials for pharmaceuticals, you'll often hear two names. Things like Tylenol, we'll get to that in a second, but is also the generic name is acetaminophen. That is the convenient name for the chemical. Now the chemical name itself is more complex, doesn't need to concern us here. But there's the generic name, which is just the name that pharmaceutical companies use to refer to that substance. There's also the brand name. So the name that the drug is marketed under. And of course, competing companies can have the same drug and have different names for it. But anyway, we have diacetylmorphine, a chemical. The generic name is diamorphine. The brand name is heroin. Many people don't know that heroin was actually a brand name. The Bayer company, the same company that makes aspirin, developed heroin. They chemically modified morphine and named it heroin. It was sold commercially. Most people think of heroin as a generic name or a chemical name or even just a street name. But it was, in fact, a brand name. It was marketed under the name heroin. Now, of course, Bayer doesn't make a big deal when people use the term and don't refer to Bayer's trademark. They're not going to push that issue. But heroin is a brand name, technically speaking. Of course, there are also things, especially for illicit drugs, like street names. So heroin is referred to as smack or H or a number of names I'm sure I'm not aware of. But this is another way of referring to the same substance. So we have all these different ways of referring to a drug, and it's all the same thing. It just depends on the context. And of course, to make things even more complicated, we often have names for naturally occurring substances, things like tobacco, where the active ingredient, the main active ingredient is nicotine, which is the chemical name. But tobacco is the name of the natural product that's most visible. It's also true for things like opium, which is actually a mixture of chemicals. Okay, so that's it for categorizing drugs. Again, that's going to sort of frame our course, at least the last two-thirds of the course, when we talk about individual drugs. Now we're going to move on to routes of administration. What does that mean? Well, basically, it's how the drug is introduced to the bloodstream. All drugs have to go into the blood. That's really the most reasonable way of distributing them to the body and to the brain. So your book has this diagram about various ways of getting drugs into the bloodstream. Now, even if a drug has an effect on the brain, it's not really reasonable to inject it directly into the brain. Even if you do, what it's really doing is entering the blood supply. You don't want to have to inject the quantity of drug into each individual neuron that you care about. Although technologies like that are always developing, getting more targeted administration to individual portions of the brain, for example. But for now, all drugs are administered via the bloodstream. So there are various ways of getting those drugs in. You can inject them directly, either directly into the bloodstream, what's called intravenous injection. You can inject them into a muscle, intramuscular injection, or you can inject them just under the skin, subcutaneous injection. Sub from under, cutaneous meaning pertaining to the skin. So subcutaneous means under the skin. So three different ways of injecting a substance, and we'll talk about the differences there in terms of its effects. You can also breathe in the drug. There's what's called insufflation, which is just a way of saying snorting, putting it in the nose. There are a lot of blood vessels in the nasal cavity, and the drug can get absorbed through those mucous membranes into the bloodstream. You can also, of course, inhale it. This is usually through smoking. There are also inhalants that aren't smoked. They're not burned before being inhaled. But there's a lot of blood supply to the lungs. And it turns out that smoking, that inhaling a substance, is perhaps the fastest way to get it to the brain. Because as you can see through this diagram, whereas injecting something into a vein, once it's in the vein, it has to go to the heart, then it goes to the lungs, then it goes to the other side of the heart, and then it goes to the rest of the body. That can take a while. If you inhale it, that's getting directly into the blood, and it's getting directly into the oxygenated blood that goes straight into the heart and then to the rest of the body. So it's very quick, which is why smoking is a very fast way of drugs into the system. So you can smoke it, you can snort, insufflate, or inhale a substance. In addition to injecting, of course, one of the most common ways is just to ingest it, swallowing a pill, for example. And so from there it goes to the stomach and usually into the small intestine where it's absorbed. Now that's a much slower process, as we all know. It often takes a while for pills to have their effect, even if they're touted as being very, very quick. So all of this is to say that the way we get drugs in the system is by introducing them one way or another into the bloodstream. But these different methods have different advantages and disadvantages, so to speak, different effects when it comes to how quickly a drug is absorbed and what the risks are. And of course, something may be an advantage if you're taking in an appropriate amount of a drug. If you're taking in too much, then a fast delivery of the drug isn't so helpful. In fact, that becomes a disadvantage. But this table from your book labels them as such, and so we'll go over this. As I mentioned, you can take a drug orally, and that can be a slow process, but it's usually pretty safe because it's slow. You're not rushing a bunch of drugs into the system all at once. So once it's absorbed, also, drugs that are taken orally are processed by the liver. And so if you have a drug that is deactivated by the liver, then the oral intake method is not really an option. But you can put things directly into the blood, bypass the liver. Again, insufflation, very quick. Inhalation, very quick. A little difficult to control the amount, which is why it's not a very common way for pharmaceuticals to be administered in a hospital setting, for example. You don't snort very many prescription drugs. At least that's not recommended by the doctor. Also because it's potentially toxic to the lungs, to the nasal cavity, so on. Similarly for injection. So if you inject something just into the skin, if you use a subcutaneous injection, if it's irritating or even damaging to the skin, you can have what's called necrosis, which is just the death of tissue around the site of injection. So that's obviously not something you want. So the subcutaneous and intramuscular injections tend to be slower. Intravenous is typically more rapid, but not as rapid as inhalation. So a lot of these methods vary in terms of how quickly the drug will get into the system. Also, whether it'll be metabolized by the liver, and what the effects are if the substance is toxic in some way. There are also other routes, things like direct contact on the skin, um, and you can also absorb uh, drugs in the form of things like suppositories, which are obviously taken in through the intestines. But these aren't very common. We're not really going to dwell on them very much. But these are other routes that are possible depending on the drug. Some drugs are not absorbed very well through the skin, for example. Many drugs aren't. Okay, so some other factors in the effects that drugs have are how easily the drug binds to proteins in the blood. If they really bind to those proteins, then the drug is going to be circulating around in the blood for a longer time. Whereas if they don't bind very easily, then it's going to be metabolized or absorbed into cells very easily because it's not attached to those blood proteins. And so that can determine how long the drug stays resident in the bloodstream. And it's important for things like drug interactions. If you're taking multiple drugs at once, if you've taken a drug that doesn't have much affinity for those blood proteins, and then you take another drug that does have an affinity, then suddenly the high affinity drug is going to displace the low one, and now there's all this uh, free drug roaming around that got displaced from blood proteins, and so now you have this sort of bump up in the effective concentration of a drug because you've taken the second one, and that can really alter the effects on behavior and the effects on the riskiness of the drug. There's also the blood-brain barrier. So most of the body, it's pretty easy to get a drug into the body from the bloodstream. The blood-brain barrier is just what it sounds like. It's an extra layer of protection the brain has. It makes it harder to get drugs into the brain. However, drugs that are more lipid soluble, that is, they dissolve in things like oils and fats as opposed to water, uh, the more lipid soluble substances, the easier it usually is to get it into the brain. So heroin gets into the brain much more easily than morphine does, for example, because heroin is more lipid soluble. It's been chemically modified to where it's more what's called lipophilic. It dissolves more easily in fats and oils than it does in water. And so that's an issue for drug development, is not just developing a drug that's effective once it's in the brain, but getting it into the brain in the first place. There are also what are called non-specific, usually placebo effects. And we've already talked about how expectations can play a role in the effects that a drug has. And the placebo effect is an example of that exact phenomenon. So you can give someone a sugar pill, something totally inert, and yet they will often experience the effect, whether it's relief from pain or relief from depression. They'll often experience relief from the phenomenon because they expect to get it. So what do you have to do to really assess how effective a drug is? You have to account for, you have to measure these non-specific effects. So what you usually do is use what's called the double-blind procedure, which is where you have two groups of participants, one who are getting the actual drug and one who are getting a placebo. And so some of the placebo group are going to report an effect because they're expecting one. But the difference between the drug group and the placebo group, you can subtract out the effect of those expectations because both groups are expecting some effect, but the drug group will have some additional effect as a result of actually getting the drug. That may not be a big one, in which case the drug isn't all that effective, but it's measurable. Okay, so once a drug has gotten into the system, and once it's had its effect, what happens after that? Well, there's a phenomenon of drug deactivation, which is just a way of saying how the drug stops working. And the only way for that to happen is if the drug leaves the body somehow. So as long as the drug is in the bloodstream intact, it's going to keep on having an effect. So one way to get rid of it is just to excrete the drug as is. So amphetamines, for example, don't get modified in any way. You just excrete it through the urine. So that's how amphetamines stop having their effect, is you take them, they circulate around the bloodstream, have their effect on the body and the brain, but gradually the kidneys filter them out and excrete them. The other way is to turn the drug into what are called metabolites, which is just the chemical byproducts of being broken down. And then those metabolites are excreted. So sometimes a drug itself is not easy to excrete. The kidneys can only excrete certain kinds of things. But the liver is the main organ in the body that metabolizes drugs. The liver will turn it into something that can be excreted. This brings up the idea of what are called active metabolites. Sometimes a drug will be metabolized by the liver, and then what it turns the drug into still has an effect. So alcohol actually is an example. Alcohol itself has an effect, but then the byproducts of breaking down alcohol have an effect as well, and it's those byproducts that actually produce things like a hangover. It's not the alcohol itself, it's the metabolites. And so these are active metabolites because they have an effect on behavior as well. Some metabolites are inert. Once the drug gets broken down, metabolites don't have any effect, they get excreted, and that's that. But some drugs can be can turn into active metabolites. And in fact, some drug development works on having a substance that isn't initially effective, but that the liver turns into something that is. So it's not the drug itself that's first administered, it's the byproducts of metabolism that are effective in behavior. As I mentioned, metabolism usually accomplished by the liver. So that's your main organ for breaking down drugs and other toxic substances. And drugs can actually have an activating effect on the liver, so they can sort of enhance their own breakdown. So the liver has enzymes, which are molecules that break down substances. We've already met them in the topic of synaptic transmission, where they break down neurotransmitters. But drugs can affect the enzymes as well. Now, sometimes drugs can affect just those enzymes. They're not really going to affect behavior in that case, except insofar as those enzymes then break down other drugs. But a drug itself, things like alcohol, can increase the activity of these enzymes and enhance their own metabolism. So a drug can sort of initiate its own demise in the bloodstream. Okay, so tolerance. Now, once a drug has been absorbed in the bloodstream, taken up by the body and the brain, and then broken down, what about long-term effects? What about repeated usage? Well, one of the effects of repeated usage is what's called tolerance. And that just means the diminishing effect of a drug after you keep on using it. So if you keep the amount constant, the dosage, it'll have less and less of an effect. Or another way of saying that is, to get the same effect, you have to keep taking more and more of the drug, an increasing dosage. And so tolerance comes in a variety of forms. One of them is what's called drug disposition tolerance, otherwise known as metabolic tolerance or pharmacokinetic tolerance. And what that means is that the drug, for example, gets broken down more easily. So the liver starts making more enzyme that breaks the drug down, and so the drug is cleared from the system more quickly. There's also behavioral tolerance, and this again touches on the idea of expectations. So once you get used to taking a drug, it may not have the same effect on your behavior as it did before, because you can anticipate its effects and, in some ways, counteract them behaviorally. So the more accustomed you are to drinking alcohol, the more it takes, not just because your body breaks down alcohol more easily, but also because you can anticipate the loss of balance and coordination, the slurring of speech, for example, poor judgment. You can anticipate these things, and now it takes even more alcohol to get that same breakdown in your behavior. There's also what's called pharmacodynamic or functional tolerance. And this is where there's an actual change in the chemistry of the neurons. So the more of a drug that's administered, the neurons can actually change what receptors are on the dendrites. So if a lot of, for example, nicotine is being administered, the dendrites can put less and less receptors, fewer and fewer receptors on those dendritic terminals, those spines. And so now it's less sensitive to nicotine. So what do? You have to get more nicotine into the system to get the same effect because the system has reduced how sensitive it is to the drug. And this can happen in a variety of ways. But those are the three main forms of tolerance, are drug disposition tolerance, where the body breaks the substance down, behavioral, where the change in behavior is anticipated, and pharmacodynamic, where the chemistry of the neurons changes to where they're less sensitive to the drug. And pharmacodynamic, that last form of tolerance, is mainly what's responsible for withdrawal symptoms. So if the brain comes to expect, so to speak, a certain amount of morphine in the system, then once that morphine is taken away, instead of being sensitive to pain at a normal level, because the system is accommodated, has gotten used to the amount of morphine in the system, now you can be super sensitive to pain once that morphine is taken away. And so you get things like the opposite of the effect that the drug usually has. And so you have increased sensitivity to pain under opioid withdrawal, for example. There's also a phenomenon of cross tolerance, which is a way of saying that we become tolerant to drugs in sort of family groups. So if I repeatedly use heroin, there's a good chance I'll become tolerant to morphine as well, even though chemically it's slightly different. It's similar enough that my sensitivity to a drug I haven't been using uh, will depend on its similarity to drugs that I have been using. Okay, so that is it for this time. Next time, we will start talking about drug use in more of a social perspective. So we'll talk about things like drug toxicity, which occurs at an individual level but has social ramifications. We'll talk about models of dependence. So drug addiction has been around, drug dependence has been around, drug use has been around for a very long time. And so over the course of time, there have been various models, various theories about why drug dependence occurs. And so we'll go over some of those. Also, the relationship between drug use and crime. So crime is a social phenomenon stemming from drug use. To what degree, how tight is that linkage? So those are all things we'll talk about next week, and I will see you then.